Hello and welcome to MRCPsych on the Go Revision Essentials. My name is Dr. Alapasurlicker and I'm a psychiatry trainee in the west of Scotland. Like many of you, I spent a lot of time commuting. This was valuable time that I could have spent revising for the MRCPsych examination. And so, I've started this podcast to help you revise on the go. Each episode breaks down one high-yield topic mapped to the syllabus. This is then followed by 5 questions to help reinforce your learning. So, grab your headphones, turn travel time into revision time, and let's get started. In episode 29, we covered the ICD-11 diagnostic criteria for post-traumatic stress disorder. We explored the 3 core symptom clusters: re-experiencing, avoidance, and a persistent sense of current threat. In this episode, we turn to complex PTSD, sometimes referred to as CPTSD. This is a diagnosis introduced in ICD-11. It was created to capture something that clinicians had long observed, but that the old classification systems struggled to describe. Complex PTSD develops following trauma that is prolonged, repeated, and difficult or impossible to escape. Common examples include childhood abuse, domestic violence, human trafficking, and torture. The key distinction from PTSD is not just the severity of symptoms, but their nature. A single traumatic event, such as a road traffic accident, tends to leave a person's sense of self and relationships relatively intact. They may relive the event itself, but who they are remains largely unchanged. Trauma that is prolonged, repeated, and interpersonal is different, particularly when it occurs during childhood or within a relationship of dependency. It shapes the very foundations of how a person sees themselves. It affects how they regulate their emotions and how they relate to others. To meet criteria for complex PTSD, a person must first meet the 3 core PTSD clusters we covered in the previous episode. This can be remembered with the mnemonic rat, re-experiencing, avoidance, and a persistent sense of current threat. In addition, ICD-11 requires a second layer of symptoms in 3 domains, called disturbances in self-organization. The first domain is affect dysregulation. This is difficulty managing emotions. It can include explosive anger, emotional numbing, or rapid switching between emotional states. This can feel bewildering to both the person and those around them. The second domain is a negative self-concept. This is a pervasive sense of feeling damaged, worthless, and defeated. It can include a guilt or failure related to the traumatic event itself. It is often experienced as a fundamental truth about who the person is. The final, third domain is persistent difficulty maintaining relationships and feeling close to others. This is often characterized by mistrust and fear of abandonment. Some individuals avoid intimacy altogether. Others become intensely and rapidly attached. Remember, complex PTSD requires the 3 core PTSD clusters, plus disturbances in self-organization across 3 domains: affect dysregulation, negative self-concept, and difficulty sustaining relationships. It arises from prolonged, repeated, and interpersonal trauma. A useful way to remember the 3 additional domains is the phrase believe, feel, relate. What I believe about myself, how I feel and regulate my emotions, and how I relate to others. People with complex PTSD often do not connect their current difficulties to their trauma history. This is particularly true if the trauma occurred in childhood and has always been their baseline experience. For someone who has never known anything else, hypervigilance does not feel like a symptom. It feels like common sense. Mistrust does not feel like a disturbance. It feels like an accurate reading of how the world must work. This is one of the reasons complex PTSD is so often missed in clinical practice. They present with depression, anxiety, or relationship difficulties, rather than saying, "I was traumatized." Sometimes they present with somatic symptoms that clinicians find hard to manage. The trauma history only emerges with careful, sensitive inquiry. This brings us to an important differential diagnosis: personality disorder with borderline pattern. This is commonly known as borderline personality disorder, BPD, emotionally unstable personality disorder, or EUPD. Both can present with affective instability, difficulties in relationships, and a negative self-concept. But how do we distinguish between these conditions? In complex PTSD, the negative self-concept tends to be more stable. It is a pervasive sense of being damaged rather than a self-image that fluctuates. Identity disturbance is considered more characteristic of personality disorder with borderline pattern. This is where someone has a shifting sense of who they are. Their fear of abandonment leads to frantic efforts to avoid it. However, in practice, the two conditions frequently co-occur, and a careful trauma history is essential in either case. The distinction matters less for the purposes of compassionate, trauma-informed care. It matters more for guiding which evidence-based treatment pathway is most appropriate. We will discuss personality disorders in more detail in future episodes. Remember, a thorough trauma history is essential regardless of which diagnosis is made. We turn now to treatment. A phased approach is recommended by NICE to manage complex PTSD. This reflects the fact that standard trauma-focused treatments can be destabilizing if used too early. Phase 1 focuses on stabilisation and building affect regulation skills. This includes psychoeducation about trauma responses and grounding techniques. It also involves building a basic sense of safety, both in the therapeutic relationship and in daily life. For many people, this phase alone can be extremely therapeutic. Learning to recognise and tolerate intense emotions without being overwhelmed by them is foundational work. Phase 2 involves trauma-focused processing. This uses the same evidence-based therapies covered in the previous episode. Trauma-focused cognitive behavioural therapy, or TFCBT, and eye movement desensitization and reprocessing, known as EMDR. This phase is only attempted once the person has sufficient stability to engage with it safely. Phase 3 focuses on integration and reconnection. This means rebuilding identity and relationships beyond the trauma. Recovery is not only about reducing symptoms, it is about helping someone build a life and a sense of self that is no longer organised around survival. Attempting trauma processing before stabilisation is achieved risks destabilisation and disengagement from treatment. A person who is flooded with traumatic material before they have the regulation skills to manage it may not experience this as therapeutic progress. They may experience it as re-traumatization, and they may understandably not return. NICE recommends that trauma-focused therapy for complex PTSD should be longer than the standard course offered for PTSD, reflecting the additional work required to address disturbances in self-organisation. Remember, complex PTSD requires a phased approach, stabilisation, processing and integration. Trauma processing should not begin until stabilisation has been achieved. Second, on medication. NICE does not recommend drug treatment as a routine intervention. The evidence base for medication is limited. But this does not mean medication has no role at all. Medication can be used to target specific comorbidities like depression or a sleep disorder. They can also be used when symptoms are so severe that they prevent the person from engaging with psychological therapy at all. NICE suggests that an antipsychotic, specifically risperidone, may be considered alongside psychological therapy for adults with disabling symptoms, such as severe hyperarousal. Additionally, NICE suggests considering venlafaxine, a serotonin and noradrenaline reuptake inhibitor, known as a SNRI, or a selective serotonin reuptake inhibitor, known as an SSRI, such as sertraline. These are offered alongside psychological therapy, supporting the person through the process of trauma-focused treatment. As discussed in the previous episode, prazosin, an alpha-1 adrenergic antagonist, is used in some specialist services for nightmares, but is not officially recommended by NICE. A final clinical note. People with complex PTSD have often had repeated negative experiences with services, sometimes including being labelled as difficult, attention-seeking, or untreatable. Trauma-informed care means recognising that what looks like difficult behaviour is frequently a survival strategy, one that once made sense in an unsafe environment, even if it no longer serves the person well. Holding this in mind and approaching the person with curiosity rather than judgment is often the first step in a long road towards recovery. As mentioned in the previous episode, The Body Keeps the Score by Bessel van der Kolk is particularly relevant here. It contains substantial discussion of developmental trauma and its lasting effects on the body and the brain. Now, let's test your recall. I will read out 5 exam-style questions. After each one, I will pause for 10 seconds so you can attempt them before hearing the answer. Question 1. A 34-year-old woman presents with emotional outbursts, chronic shame, difficulty trusting others, and intrusive memories of childhood abuse. What diagnosis should be considered? Complex PTSD. Question 2. What are the 3 domains of disturbances in self-organisation in complex PTSD? Affect dysregulation, negative self-concept, and persistent difficulty maintaining relationships and feeling close to others. This can be remembered by believe, feel, and relate. Question 3. What type of trauma typically leads to complex PTSD as opposed to PTSD? Trauma that is prolonged, repeated, and difficult to escape, particularly when interpersonal in nature. Question 4. A person with complex PTSD is too dysregulated to tolerate trauma-focused therapy and also has a moderate depressive episode. How should their medication be approached? NICE suggests an antipsychotic such as risperidone, used off-label alongside psychological therapy. SSRI like sertraline or venlafaxine and SNRI may also be used as adjuncts. Medication should support access to therapy. Question 5. You are reviewing a person with complex PTSD who remains highly dysregulated and unable to engage with trauma processing. What approach is recommended and why? A phased treatment approach. Phase 1 focuses on stabilisation and affect regulation before attempting trauma processing. Let's summarise what we have learnt today. Complex PTSD requires the 3 core PTSD clusters: re-experiencing avoidance and a persistent sense of current threat, remembered as RAT. In addition, it requires disturbances in self-organisation across 3 domains. These are affect dysregulation, negative self-concept, and difficulty sustaining relationships. This can be remembered as believe, feel, and relate. It arises from prolonged, repeated interpersonal trauma. Treatment follows a phased approach. Stabilisation, trauma-focused processing using TF-CBT or EMDR, and integration. Stabilisation must come first. Treatment is usually longer than the standard course offered for PTSD. This concludes our 2-part series on PTSD and complex PTSD. In our next episode, we ask why some individuals are more vulnerable to stress than others. We will explore vulnerability and protective factors, and Friedman and Rosamond's Type A behaviour theory. Thank you very much for listening to this episode of MRCpsych on the Go Revision Essentials. I hope this episode helped to move your revision forward. If you have any questions or just want to continue the discussion, you can find me on LinkedIn at MRCpsych on the Go, spelled MRCPsych on the Go. This podcast is about making revision accessible. If you found it useful, liking and sharing it with others helps the goal more than anything else. That's it for today. I'm Dr. Alapas Ehrlicher, and as always, keep revising on the go.